So good afternoon again, ladies and gentlemen. I hope you've all got your lunch and you enjoyed the first couple of sessions. The next speaker is slightly different. I had an email out of the blue from a gentleman who said, I've got this PhD thesis that I'm working on, and I'd like to be able to come, if there's space, to join you. And I read through it and I thought, yeah, you know what? I think I can find time for this. I think we can definitely fit this in somewhere. So he's kindly agreed to come and do the lunchtime session for us. So Brandon Eberl is currently a PhD student with the Biomedical Engineering Program at Wake Forest University and the School of Medicine. So his PhD dissertation works on sort of focusing on developing benchtop techniques to investigate the underlying mechanisms that sort of modulates what they call the zeta potential. So it's a key biophysical parameter responsible for cell aggregation. And so he's looking at how can we actually sort of monitor human red blood cells and use as a biomarker in extracorporeal circulation. So without further ado, Brandon, it's been a pleasure to have you here. Thank you.
Thank you, Richard. Thank you, Richard. And yeah, like Richard said, my name is Brandon Eberl, currently a PhD student at Wake Forest University School of Medicine in the Biomedical Engineering Program. I do not have any disclosures other than the fact that I am not a perfusionist. I am a mechanical and biomedical engineer by training. So I might be a little bit rusty on some of the perfusion directly related clinical stuff, but that's where you guys can kind of fill in some of those gaps. So the objectives of today's talk are to provide an overview of red blood cell monitoring and some of those limitations that are currently seen in clinical practice in ECMO, and then also describe the importance and implications of one of the properties of red blood cell surface charge, and then as Richard introduced, zeta potential as a potential biomarker and how we can measure that to predict blood cell damage in ECMO circuits, and then provide an overview of some of the in vitro work that I've been doing for my PhD thesis. So as we know, ECMO failure is significant often, and it is often due to primarily blood clotting, oxygenator pump failure, and as well as hemolysis. So this is probably a graph that's familiar to many of you. It's from one of the ELSA reports back in 2022, shows the incidence of thrombotic events in ECMO patients. And then hemolysis can be due to ECMO, but it could also be due to other confounding factors. But that'll increase the bleeding risk. And while anticoagulants can decrease the risk of thrombus in a circuit, that again is going to elevate your bleeding risk. So aside from monitoring coagulation markers, there's also a keen interest in looking at red blood cells. So there's a lot of work going on in the literature on platelets, but red blood cells are also an important cell type to monitor in ECMO circuits. So if we look real closely at the broad progression of hemolysis and what happens to a red blood cell. So you have that healthy bioconcave shape that has the high surface area to volume ratio to deliver oxygen to tissues. And then over time, either through an ECMO circuit or other confounding factors, you have morphological alterations, and then lastly, hemolysis. So hemolysis is really where, and plasma-free hemoglobin, is really where we see that measurement of red blood cells in ECMO. And here's a review paper from the early 2020, 2019, looking at plasma-free hemoglobin and hemolysis incidence in ECMO patients and the clinical applications for that. So some of the limitations that you all have probably seen in your own clinical practice is there's a low temporal resolution of plasma-free hemoglobin. So as one other speaker mentioned earlier, they only took measurements every once, and then they didn't take them again until the next day. So there's a lot of time that elapses before you're getting consecutive measurements. So by a show of hands, does anyone actually measure plasma-free hemoglobin greater than maybe once or twice daily for ECMO? Okay. So, and then there's also the high cost for measurement, and then there's significant measurement variability that I've seen in the literature between centers and between patients, frankly. So surface charge is a property of red blood cells that allows them to basically repel one another and keep them from sticking together in circulation. So on the surface of the red blood cell, you actually have surface proteins that are negatively charged, and those negative charges, based on physics, will like charges repel. So you will get a repulsor, which will keep them from aggregating. So the way that we can measure that is a property called zeta potential. So when you stick a red blood cell in an electrolyte solution, whether it be saline or plasma, you have ions that will form on the surface, that will attach to the surface of the red blood cell. And I think you can see, I don't know if my laser pointer is working, but you have ions that attach to the surface of the red blood cell, and then as you move away from the surface of the red blood cell, you have multiple layers of charge that will build up. And then what zeta potential is essentially a differential of charge that we can use to characterize how likely the cells are to aggregate. So real quickly, this is some engineering background stuff, but I'll kind of explain it to you at a high level, to how zeta potential works and how we measure it. So essentially, since the cells are charged, we can apply electric field across the cells in a experimental cuvette system. So the cells will move in response to the electric field. And so we can get a bulk measurement of the cell surface charge based on light diffraction. So there's a laser that simultaneously gets shot through the sample as the cells are moving. Based on the light refraction, we can infer what the cell's velocity is, and then from there we can then infer what their surface charge or their zeta potential, like their differential in charge for voltages, based on the cell's properties and as well as the buffer, the medium that you're suspending the cells in. So there's been a lot of work just in the literature on zeta potential and different applications. So I'm highlighting some more of the cardiovascular related and some more applicable perfusion related applications. So this is some work by some collaborators. They looked at a normal red blood cells, like in circadian rhythmicity, you can see changes in zeta potential just over time, like over a 24-hour period. And the healthy range of red blood cells is around this 25 to 40 millivolt range, and it's negative because they're negatively charged. There's also been studies that look more closely at the coagulation mechanisms and how red blood cells will, like their role in that process. So this is a study that looked at fibrinogen concentration and RBCs, looking at old and new RBCs in reference to the zeta potential. And they've actually seen that the age of red blood cells, which I'm going to get into a little bit later on in my work, as well as the fibrinogen concentration, will ultimately alter the surface morphology and surface charge, and can be an indicator of coagulation downstream. And then here's a more clinical application looking at changes in red blood cell surface charge and zeta potential over in different cardiac pathologies, so myocardial infarction, hypertension, etc. So what we're really interested in looking at is in ECMO or an ECMO circuit, does blood flow, so exposure to flow, because all the other studies were done in static conditions, does exposure to flow impact the zeta potential or the surface charge of RBCs? And then because in ECMO you use a lot, oftentimes you're transfusing blood, does blood storage also alter, does it for one have an effect on zeta potential, but then does it also alter that response that we see from flow? So what we're interested in looking at is the pre-hemolysis route. So we're hypothesizing that we could also use zeta potential not only to monitor RBCs in ECMO, but also use it as a pre-hemolysis indicator in addition to other clinical metrics like plasma hemoglobin. So we're looking at this pre-hemolysis range. So our experimental approach, so this is my little nice tabletop ECMO circuit. And so we procured human whole blood from a blood bank local to the North Carolina Raleigh-Durham area, and we stored the blood up to 49 days. And then at different time intervals, we alkaline some of that blood out at 7, 14, 30, and then 49 days, and 21 days also. And we looked at the red blood cell changes in the ECMO circuit. So we isolated the red blood cells from whole blood. So we're not looking at whole blood, we're just looking at the red blood cell changes. So we isolated from whole blood, and we resuspended them in saline in our circuit at a 10% hematocrit to allow for these additional storage studies, so we could use the same donor across multiple storage durations. And so we circulated the blood for 12 hours continuously. Every 2 hours, we took a blood sample, and we took zeta potential measurements, as well as plasma free hemoglobin, and then some other biomarkers that we're currently looking at analyzing, including sialic acid, which is that membrane surface charge protein, which I'm not showing in this presentation, but we're also going to look at that in future studies as well. So some of the results. So we found that after just 6 hours of flow, there were differences observed between static and flow samples up to 30 days of after 30 days of blood storage. And then and we also see changes in the cell morphology, and also overall cell concentration between the static and the flow samples. So then if you extend that out to 8 hours, because most of these in vitro circuit studies for ECMO and even cardiac bypass in the literature only go out to 6 hours, and some have gone out to 12. Most of them are only limited to 6, which doesn't really mimic the clinical scenario that you would see in an ECMO, where they're on circulation for 24 plus hours. But at 8 hours, we start to see some effect. We start to see a significant difference between static and flow samples as early as 14 days of storage. And then similarly with the morphological changes, you also see changes in cell concentration, but and a decrease in cell concentration between static and flow as well, which are supportive of our zeta potential measurements. And then if you go out to 10 hours, and then also in 12 hours, you see similar significant differences between the static and flow across storage duration. But what you also see, especially at this later blood storage time point, the 49-day and 30, is the greater magnitude differential between static and flow. So there's something happening with the surface charge there that is essentially the cells are aggregating, or they have a higher propensity to form aggregates and then eventually lead to clotting if you were to introduce all the clotting factors and other blood cell types. So then we were interested, so this is just some very preliminary pilot data. During our 49-day storage date, we were interested in seeing if we could actually measure plasma free hemoglobin. So we're going to rerun this in future studies because this was just a single one-off trial. But what I'm showing here is that you see some differences in, you don't see differences in static and flow at 6 and 12, which was a little bit 12 hours at day 49, which honestly was a little bit perplexing to us, because, and what I wanted to get some of y'all's insights in clinically possibly, is because you would expect a greater hemoglobin release and hemolysis at this longer circulating times and in longer blood storage. So what we're thinking is, when we take it out of storage, what we're hypothesizing is possibly there's an initial rapid hemoglobin release going from 4 degrees centigrade in refrigeration to 25 degrees Celsius in our circuit, and then after that it stabilizes, or there's other factors leading to differentiating between the zeta potential changes and the hemoglobin, plasma hemoglobin levels. And then this is just a reproduction of the graph that I shown over here, where we're just comparing zeta potential to plasma free hemoglobin side by side. And you can see that there's significant changes with zeta potential, but we don't see any change at 6 and 12 hours with hemoglobin. So we're still looking at that, but I'd be interested to get you guys, your all's clinical insights on that, why that might be, or or ways to kind of look at alternative options in the future. So then, whoops, I think I went back. Okay, so then the main takeaways of this are that we are observing significant changes in zeta potential due to flow. So that is pretty significant because it actually is showing that as we increase blood storage duration, you have less and less time on flow before you're starting to see cell surface charge changes. And then that also kind of goes into the second point where we're seeing flow-induced changes that are amplified by the blood storage duration. And then we think that zeta potential, based on this pilot data, might be a more sensitive biomarker potentially for monitoring red blood cells in ECMO compared to like plasma hemoglobin, but we're going to do some additional testing and additional studies to look at that as well. So one limitation, and I'll get into this in future work in a minute, one limitation of this study, this initial study, is that we did not use an oxygenator. So part of that was we just wanted to look at the flow response in an ECMO circuit on red blood cell surface charge and zeta potential changes. But we have future work that I'm going to discuss in a second that goes into ways that we're going to integrate an oxygenator and other ways to probe these changes that we're seeing in zeta potential more mechanistically. So some of the clinical implications that I've kind of been digging through the literature kind of summarized, and one of the big ones that we've seen is blood storage and use of blood age in ECMO. So from what I've seen in the literature, most studies, there's no consensus, most studies consider fresh blood, depending on the center, 14 days, maybe up to 21 days. And then others might say it's less than 14 days. So there's really no consensus, but what we're seeing with the zeta potential is pretty significant. At 14 days, after just 14 days of storage, you're limited to only 8 hours of circulation before you start seeing aggregation and surface charge changes. So that's also something else to explore in terms of clinical guidelines, is how do we better differentiate and those categories essentially of fresh versus old blood, and how do we best implement those practices for our patients. So some future work that I'm going to be working on this summer, and then throughout the remainder of my PhD at Wake Forest. So we're going to, like I mentioned earlier, we're going to integrate a PIXI pediatric oxygenator. So we wanted to keep the reservoir volume small for the oxygenator to limit blood volume, because we're trying to do those single donor, multiple storage date experiments. So we're going to integrate an oxygenator and look and see if there are compounding oxygenator effects on this zeta potential surface charge biomarker. And then we're also going to see if we can better understand some of the compounding factors, such as blood storage and even blood damage in these circuits, so like shear effects. So there was a study out, it was a pretty old study in 2005, that looked at blood damage in a roller pump circuit, and based on extrapolating out our circuit volumes and those metrics, we've seen that only about 3% of the blood cells, or red blood cells, are actually undergo shear damage. So we want to see like what the sensitivity of our metric is to picking up shear, and we're going to do that in a microfluidic, very controlled type study, looking at different shear rates and blood storage, etc. So then, just to real quick highlights for the other applications of zeta potential in our laboratory. So we broadly focus on electrophysiology of red blood cells and other cell types. So we're looking at chemical changes and a chemical exposure to red blood cells under oxidative stress processes, and how that might modulate the zeta potential and shift the zeta potential, modulate the surface charge, as well as we've applied some clinical. We've done a clinical study with a collaborator at Wake Forest looking at myoglobin mutations in RBCs. We haven't seen anything with that study currently, but that work is currently ongoing. And then some other non-RBC work. We have an undergraduate student in our lab that's looking at glioblastoma cells to look at for cancer patients and look at cancer treatments as well. And so in addition to zeta potential, we also look at other cell biomarkers such as membrane conductivity and capacity. And so some of the membrane properties of red blood cells, so looking at those ion channels and changing in ion concentrations, as well as cytoplasmic effects as well. And then there's a QR code to our laboratory website. So if anybody else is interested in some of those non-zeta potential or even the zeta potential studies that we have ongoing, you're welcome to scan the QR code. So I want to thank Richard and the rest of the team for inviting me. First and foremost, this has been awesome. A very, very rewarding experience. I've never been to a clinical focused conference before, so it's been really fun. And then I also want to acknowledge our laboratory, all of our undergrads, my PI, Dr. Aaron Hensley, as well as my PhD committee, and our clinical collaborators at Duke and UNC Children's Hospital. So with that, thank you so much, and I look forward to your questions.
So thank you very much. I mean, that's pretty tough coming and talking to a clinical room, so well done. Any questions from the floor? Yeah.
Brandon, great talk. A quick question, your PhD, your committee, are there perfusionists on there? Were those the people listed in your clinical collaborators?
No, we do have one. We actually have a couple. There are no perfusionists on my committee specifically, but we've been working with some other perfusionists at Wake Forest, Scott McGee and some others, Scott Kopes actually, they're both Scott. And they've been very helpful giving some clinical insights and also in that kind of regard. But no perfusionists are actually on my committee, but they have been informing the work in terms of circuit setup and that sort of thing.
Very good. One question I have for those of us who, obviously most of us don't specialize in this area, when you're talking about charges that are this small, two questions. Is there any measurement of the charge in the fluid that in other words, after you're recirculating or you're having flow for 8 hours, do you measure whether or not there's any change or net charge of the fluid in total before you measure those cells? And question number 2 is, has anyone on your committee or any of your collaborators ever advanced the possibility, it's somewhat hit or miss, but I know a lot of us have probably experienced this situation where if you're using a roller pump to generate flow, there's at least the potential to generate a static charge that it gets transferred through the system.
Yeah, so actually to address your first question, so I didn't show the data in this presentation, but the way that we validate the zeta potential measurements in terms of charge, so red blood cells, what's responsible for their surface charge is a glycophorin surface protein that is negatively charged. It's called sialic acid. It's actually common to pretty much all biological cells, and we can actually measure the concentration of bound and unbound sialic acid, in which that was also what I was doing as well. In the Buffy coat, pre and post flow, and see what that charge shift is, and that's kind of how we correlate that back to zeta potential. And then to your second question related to the roller pump, so that is actually a question that I've gotten a couple times at this conference, and I'm actually going back into my committee. I'm meeting with them in a couple weeks, and I'm going to try to attempt to address that. So we primarily use the roller pump just logistically. It was easiest to obtain. Actually, one of my committee members is in the cardiothoracic surgery department. He already had roller pumps, some of his other collaborations. But yeah, that is also something that we're looking to address, and also the issue of vibration and heat generation in our circuits, because we're getting pretty significant fluctuations in vibration and also heat generation. So that's also something to consider. But thank you so much for your question.
Great talk and really, really cool PhD. Well done. My question is regarding, you said you can measure oxidative stress in the red blood cells.
Yes.
So the question is, what technique, because ROS can be very labile, it spontaneously comes and goes, so most people rely on indirect markers to do this. So what is your measure of oxidative stress? And my second question is, why not white blood cells as well? Because post-surgical immune suppression is a big problem. ROS is needed to actually really kickstart white blood cells. So you can look at this during the operation on the pump. So first of all, what's your measurement of ROS? And secondly, are you looking at white blood cells as well?
So I am not specifically looking at white blood cells. We did have an undergraduate student that was looking at a white blood cell model, and so I would have to direct you to either our laboratory website or my PI to answer that question specifically. But then in terms of the ROS, so I actually included some of the OS-based slides. So this is, I think you can see this is some of the data from our OS study. And so we're measuring, we're chemically inducing OS with hydrogen peroxide at different concentrations. And then we can measure the ROS by tagging the cells with a fluorophore. So when it undergoes flow cytometry, we can measure the absorption of the emission and absorption rates. And so what we're seeing with this OS, interestingly enough, is there's actually subpopulations that are forming in the later OS, the higher OS treatments. So it's a very heterogeneous mixture. But that's a potential way we could measure OS or ROS in clinical practice potentially. And the zeta potential measurement, what I will say to you is one of the benefits is it takes less than 5 minutes to take a single zeta potential measurement, or to take multiple zeta potential measurements to replicate. So it's a very more highly it has a better temporal resolution than a lot of these clinical, like pre-hemoglobin release. So it might be an alternative or an additional indicator that you could use in clinical practice potentially. So.
Thanks for coming to talk to us today. I wanted to ask a question about, kind of a technical question about making these measurements.
Yes.
So I just heard you say like about 5 minutes to get a good measurement. Could you teach us what is the biggest obstacle to making, in terms of interference or problems in making your measurements? What's the thing that frequently confounds? What are your confounders, and what are the things that prevent you from making good measurements?
So one of the main things that we've seen is, so the zeta potential, and actually I can go back to this in case Tim might help describe. Let's see. Whoops. Yeah. Yeah, I'll just do that one. So one of the things is cell concentration. So zeta potential is a bulk measure of cell charge or differential in charge. So we're measuring the cells that are left, which I think is why we're not seeing plasma hemoglobin measurements. Is cell concentration is a big thing, and then that's primarily one of the bigger factors in zeta potential. There's also things like conductivity in the media that we're using. We use a low conductivity media to reduce that risk of the cells hemolyzing. So I would say cell concentration is probably the biggest limiting factor for zeta potential, and also controlling for the pH. Some of these the pre-pilot data, when I first ran the circuit, we did not control for pH. We see massive zeta potential fluctuations, just inter-replicate fluctuations, just because the pH was shifting so much. So we've now controlled for that, and that's been a big help in terms of stabilizing some of these measurements. Does that answer your question?
Whilst you're checking the chat, just I suppose a technical question. Obviously, you can see what you need in order to measure it. How big is this in reality, and how much blood would you need? Could it be something that you could make into a very, very small point of care test that could sit on the bypass machine, for example?
Yes. So the actual system. Do I have a picture of it? The actual analyzer is like a tabletop system, but in terms of blood volume, we need about 900 microliters to 1 ml. So very, very low. So when I draw blood cells off the circuit, I draw a discard just to make sure we're actually getting that flow response from the stop, drawing off from the stopcock, and then I draw another ml. So really, every 2 hours, only 2 mLs is really coming off of the 100 ml circuit. So very, very little blood volume is actually needed to run these measurements.
I have one.
Yeah.
Are you monitoring MYO9B because its altered expression may reflect tumor progression, invasiveness, or treatment response?
So that is actually a separate, completely separate from the ECMO study. So they were that was with a collaborator. We were looking at can a MyoB mutation, what are the differences in terms of repair for oxidative damage on red blood cells. So that's a completely separate study from the ECMO, but that potentially has implications for cancer treatments. But thank you so much.
And yeah, there's one comment was in there, which is it's great to hear from Biomed. So thank you very much for coming down. If there's no more questions, we'll wrap up slightly early, but just a big thank you to coming down and talking to us. And yeah, it's not easy to stand in front of a load of clinicians and talk science. So well done. Thank you very much.
Thank you so much.